Kia ora whānau. Cheerful topic for today, but it is an important one, so thank you for the invitation to speak here. Some brief disclosure statements. Oops. There we go. So I'm lead psychologist at Habit Health. I have a team of about 30 psychologists across New Zealand. I'm also a member of the New Zealand College of Clinical Psychologists and its assisted dying work group. But the views expressed in this presentation are my own professional personal opinion, not an official view of these organisations, which in any case are made up of people with varying opinions. So, clinical psychologist, what does that mean? So, 7 or more years university training, clinical placements in various healthcare settings, and trained to help people survive and thrive despite significant mental, physical health challenges. So, for example, I've worked with people injured, Canterbury earthquakes, the Christchurch mosque shootings, trauma, disability, amputation, paralysis, anxiety, depression, grief, all of these sorts of things. So, assisted dying, why? Why is this being advocated for at the present time? And the reason is our limited ability to alleviate suffering in a small but significant minority of cases. And depending where you draw the cut-offs, you might be looking at perhaps 2 to 5% of people dying, having bad deaths despite good care. And some people say, well, that's not a large number of people, but that's several hundred people, for example. And as a clinical psychologist, every one of them matter. They matter to their loved ones and so on. And so what does that mean? So these sorts of difficulties, multiple invasive treatments and surgery, intense pain, hemorrhage, swelling with fluids, inflammation, nausea, vomiting, declining function, physically and cognitively, trouble breathing, swallowing, drinking, eating, and people's physical and social worlds just shrinking, and an inability to choose your actions and gain pleasure from life. And listen, people do, despite many of these symptoms, most people do still live very good lives. But there's also a dose-response relationship here. As you pile on more and more of these difficulties, people's ability to cope effectively with them decreases significantly. I did encounter a bit of a dilemma here because I didn't want to actually go into some of the more graphic detail and give graphic examples. I don't think that's necessary. If you really want to see that, then please just Google the stories of people experiencing this. Instead, I'll use an example which is analogous, and it's been in the still shocking and so on, but most people are already aware of it, have already thought about it, and it has some similarities, which is, of course, the 9/11 situation with people who faced this really unpleasant choice of a slow death, suffocating, dying due to heat and so on, or throwing themselves hundreds of stories to their deaths. And it's a choice no one wants. And so pain. Now that is actually only a concern in about that people raise in about a third of cases of assisted dying. It's often this combination of other factors as well. But nonetheless, neuropathic pain, which is often very difficult to treat, is present in a number of cases, and people often describe this as a burning sensation. They often have allodynia, so they're very hypersensitive to any sort of touch, clothing on, for example. And this was also notable for another phenomenon, which was evidence here now too, and that is the religious condemnation of these people for choosing suicide, and then some people have criticised them for throwing themselves into hell. So I will let you make what you will of that, but I'll also come back to that again in a little bit. So this current cruel choice that people face, to suffer unbearably or to choose to end your own life. So people already have the right to refuse life-saving treatment, and the rights, for example, to starve or dehydrate yourself to death. An estimated 5 to 8% of suicides that we're aware of are people with terminal or remedial illness. And often, very tragically, this is people who are dying before they really had to, because they needed to retain sufficient self-determination, control and action to be able to actually do this act themselves. And they can't get support to discuss this and other options with health professionals, because health professionals will not help them. It also places family members and close friends into a very difficult position, because it's illegal to help someone with this, though not illegal for a person to do it themselves. And that leads to these sort of observations. A health system where people can refuse medical treatment and intentionally die a slow and painful death, but can't access medicine to pass peacefully, is cruel and causes unjustifiable suffering. And the expressed desire that so many people have is this, that I just want to hang in there until I can't, and then I want this peaceful end. So, this current End-of-Life Choice Act, just a bit of history to it, it builds on past acts which are cross-political, introduced by MPs from National, New Zealand, First, Labour and ACT, starting in the late 1990s. This current act has been over 40,000 submissions considered, over 100 amendments. And as Parliament has voted to pass this, subject to this referendum that will be in your hands pretty shortly. Opinion polls show a large majority in favour, and have for some time. So there's the polls over time. So about 70% in favour, 15% opposed, 15% unsure. Pretty stable. And as I said, it's cross-political. So here's Helen Clark, and she says, I believe the End-of-Life Choice Act is a compassionate in giving people who are suffering in ways that are very difficult to alleviate the right to say their farewells at the time of their choice. And here's Paula Bennett. I believe that for those who are terminally ill, they should get a choice about dignity and a choice to be with their friends and family. So just to briefly cover this act, and I'm not sure to what extent you're already familiar with this, but I'll just quickly cover this. So the Act authorises a doctor to administer or prescribe a lethal dose of medication to competent adults who meet strict criteria, should they directly and voluntarily request it. Two doctors need to determine that the person suffers from a terminal illness that is likely to end their life within 6 months, is a significant and ongoing decline in physical capability, experiences unbearable suffering that cannot be eased, is able to make an informed decision about assisted dying, and is age 18 plus, a New Zealand citizen or permanent resident. The restrictions on it: a person will not be eligible if the only reason is that they have a mental illness, a disability of any kind, or are of an advanced age. So in comparison to other countries where this is legal, this is a more restricted version amongst those that are in place elsewhere. A person must first approach their doctor to ask for life-ending medication. The doctors cannot suggest this to patients. You can, of course, stop or delay the process at any time. And if a doctor thinks a person is being pressured about the decision, at any point they must stop the process, report it to the registrar. I mentioned jurisdictions where it's legal. In those jurisdictions, about 0.5%, for example in Oregon, Washington, the US, of people choose this option for death. About 75% of patients are cancer patients. Another significant minority would be neurodegenerative conditions such as Huntington's disease. On average, life is shortened about 10 days. About 1/3 of people who request assisted dying end up not using it. But just knowing that option is there is a significant comfort for many people. And it also, the research evidence also suggests that it does facilitate a more open and honest discussion about dying and options and alternatives. And there are often, we find lower levels of psychological grief and trauma experienced both by the person involved and by their loved ones. Now there is an exception to that. For example, if I mentioned before, if you are fundamentally opposed to this form of death and your relative chooses that, and you believe them to be in hell, for example, then you'll suffer more symptoms there. So, and I should say, some of the highest levels of psychological... Sorry?
What did you say? The last point you made? I didn't understand.
Oh, if you are opposed to this act, and the people choosing this option, and your relative, for example, chooses it, you're likely to find that more distressing, not less. Yeah. Some of the highest levels of psychological grief and trauma occur in cases where someone has a relative who is begging for this option, it's denied to them, and they have to watch that process. And certainly I've encountered that. So I mentioned opposition, and I think it is really important to be aware that there is a very coordinated campaign from conservative religious organisations at the moment, with a lot of money behind it, because they don't pay any tax, to oppose this law. Now, they're just fundamentally opposed to it, no matter what form of law this could take. Opus Dei, Catholic organisations, and so on. And often they have doctrines too, for example, that suffering brings one closer to Jesus, and so on. But as they note, these religious arguments are not convincing to most people these days. These organisations hold little weight, moral weight now, with so many people. In fact, they can even be seen to be immoral. So instead they're using a number of front organisations, such as Risky Law and some others, which board is entirely made of people from these organisations, I believe. They're mounting a big TV advertising campaign, though I know one of the adverts was just so misleading that it's been rejected on Friday. But if you want to find out more about that, I'd suggest Googling this here, Graham Adams. He's done a very good investigation into that. Also, though, very important to say that many religious organisations, and in fact the majority of religious people, as far as we can tell, for example 70% of Catholics in Australia, are actually in favour of this legislation. So we don't want to just, tar everyone with that same brush. And of course, I work with many religious people, I socialise with religious people regularly, and have great respect for them. So there's a diversity of opinion there. So let's move on then from that to concerns which you may have thought of yourself, or you may see raised, and I think are ones that any reasonable, caring person may have these at some point. So one of the first, of course, is what about particularly vulnerable people? And this, and longitudinal data has been kept on this, and there is just no overrepresentation of vulnerable groups compared to the general population. So vulnerable groups being the elderly, women, ethnic minorities, people who are financially disadvantaged, people without access to reasonable health care, people with low educational status, physically disabled, chronically ill, mentally ill, minors. No overrepresentation. Now, if there is any, it's almost the reverse in fact, because as with other health care options, otherwise privileged white people are probably the most frequent users of this as well. Let's go through some other concerns. Will this increase suicide rates? There's no evidence of that. Will increase the acceptance of this option. And I think what the concern here might be is that people might choose this when actually good palliative care would be perhaps preferable. And well, already people support this. So people believe it's justified in certain circumstances. Oregon's had this law for 25 years. About 0.5% of people access it, and it's pretty stable. So I don't think that's particularly realistic concern. Another one you'll hear is that diagnosis is not 100% accurate, which is true. It's not. But medicine is about probabilities, and you may not know exactly what the story is, but right now doctors will often give quite clear diagnoses. We've got data that, for example, 95% of people within 3 months of this sort of state in prognosis will have deceased. This sort of intervention has X amount of chance of following that. And on that basis, the decision is made already to end futile treatment. People have the right to refuse treatment. People have the right to choose a slow, painful death if they want right now, without further intervention. So I think to raise this as an objection is rather inconsistent and cruel, really. Another concern is the concern about people being coerced. So the concern here, of course, is that someone's abusive relatives convince them to knock themselves off, I guess, is the way that you might put that. And I think there's several points to observe here. Firstly, there is already widespread acceptance that this is a valid choice in some circumstances, and people are already acting on this. And they're doing that without the protection of a process where they can discuss this honestly with multiple health professionals. If you're in this situation, potentially 3 doctors, including a psychiatrist, plus you'll be in a setting where there are nurses, social workers, and other health professionals very often. So you can argue that the present circumstance where you can argue that a process without doctors and health professionals involved is safer than one with that provision, that a hidden process is safer, but I just don't find that convincing, frankly. And also for these other options, we don't deny people the right to refuse treatment and so on because we're worried about them being coerced. So, another one, the concern about people doing this because they're concerned about themselves being a burden to other people. And as a psychologist, I take this seriously. And the research shows this is a concern people have. They don't want to be a burden to other people. But the research also shows this is one of a cluster of concerns people have. It's not like they just have this. It is the dominant concerns people have are about the loss of autonomy, self-determination, ability to gain pleasure in life. They have anhedonia, no more pleasure. And they're suffering from that range of symptoms. So this is a burdensome condition to themselves. And if you're an even mildly socially conscientious person, of course you're going to say, and I'm also, I'm concerned about how this is affecting other people too. I don't want to be a burden to them. So it's a concern, but it's not the main concern, and it's not sufficient in and of itself. And once again, as for the problem of coercion, I'd far prefer an open process where people can discuss this, where we can challenge perhaps erroneous beliefs around this. Rather than just pretending if we make this illegal, this problem's going to go away. It doesn't. People are already killing themselves alone violently right now. Another concern. Some medical organisations are opposed. for example, most palliative care organisations. Others are more in favour, for example, nurses' organisations. So what to say about this? Well, I think it's worth looking at the history here, because the philosophy and the ethics of medical organisations evolved. Not so long ago, doctors denied contraception to unmarried women, for example, and just in paper and news the last couple of days, 5% of women are still denied contraception because their doctors have moral Catholic beliefs against this. Homosexuality was legal. Abortion, even in cases of rape and incest, was criminalised. But medical organisations have evolved, we've become more civilised, thankfully, and I think that is very likely to be the case in this instance too. There's emeritus professor Ian Maddox, an Australian of the Year and palliative medicine specialist, has said this profession needs to sort itself out. It does indeed, I believe. Another concern that this will cause distrust of doctors. No evidence for this from overseas. And I know right now many people are actually very angry at these doctors who are denying this. And they don't trust them. For imposing their moral worldview on patients like this. And the common refrain I'll hear is people who say, if we treated animals like this, we would be prosecuted, which is true. We have more compassion for animals, it seems, in these situations. So based on my knowledge and experience, I don't believe this. Related to this is the concern that this will replace palliative care, and I've mentioned that already, that I don't believe that is the case. And indeed, the evidence from overseas that is, if anything, this is an adjunct and enhancement. It facilitates a more open discussion between patients and doctors and family and so on about options. And people are more willing to trust palliative care if they feel they still have this ability to self-determine their actions, rather than getting to a point of vulnerability where they're under the control of people who will impose their own moral views upon them. The slippery slope arguments that this will expand and start self-determining all people, and then suddenly we're euthanizing people against their will and so on. No evidence of this. The other argument here would be that you start with these boundaries, but then they expand gradually and slowly, and you start going into risky territory. So in overseas jurisdictions like Oregon, for example, this hasn't happened. Other jurisdictions, there have been perhaps wider boundaries for a start, and some limited expansion to those has been considered with much debate. And here's the thing: is it always wrong to do that? I think you really have to look and debate and discuss and look at the evidence and judge that on its merits, and that's a very difficult process. But the alarmist views being promoted there, I think, are also not convincing. Another concern is that people don't have to tell their families. Well, no, of course not. Standard healthcare ethics. And it would be wrong if you force people to, because some people have family members, for example, who have been abusive, who are estranged from, particularly dogmatic, cruel beliefs and so on. You should not have to tell a relative who is an abuser just because of a situation like this. And the other thing to take out of this, of course, is that 95% of people are having those discussions. So I don't believe that's a concern of significance. Another one, a concern that there's no calling off period. In other words, that people can choose this, request it very hastily, and make a very quick decision here. So, what to say about that? What I would say is that if people seem to be making very hasty, unwise decisions. That does raise the bar for the mental competency test that they have to undergo. So it's not impossible, but it raises the bar. And I would also suggest that you have to consider some of the most likely scenarios here, which is perhaps someone who has thought about this option, decided that they didn't request it. They don't want this, they don't need this. But now, there's in the last couple of weeks, say, of this illness, and they are suffering unbearably, and they say, I've changed my mind, please don't have this. In that circumstance, I believe it is unreasonable and callous to impose some arbitrary length of time on that. And I think the evidence from overseas jurisdictions is the proposed form of law we have here works and is the best version. So that's not necessary. So as you can probably tell, I think overall this has strict criteria, has adequate safeguards. It is the compassionate choice, is that. That's my opinion, personally. And I'm happy to take questions. And I'll just end with one other thing, actually, which is some people have said this is, you're concerned that this has been rushed through and it's hasty and so on. Law Professor Colin Kavanagh from Otago, as he says, he can't think of any other law in New Zealand history which has been debated and considered as much as this one has. And as I just illustrated, this has been considered for a couple of decades now, so that's simply not true. So.
Last question.
Well, I was wanting to wonder if you could clarify what's written in terms of are medical professionals required to participate in the...
No, they're not required to participate.
There's no requirement.
Yeah, they can conscientiously object. Okay, thank you.
Thank you, Mark.
And I will be around if you want to have more discussion. Thank you.